So while people are still dialing in, we typically start on time. So welcome everybody to today's CMR Journal Club. I'm Matthias Friedrich, and I'm today hosting from Montreal in Canada. I'm on service, and therefore please apologize should there be traffic in the background. I'm on CCU service, and it is quite a busy day. It has been a busy week. Today's topic is very interesting, and I want to already thank the two first authors of the paper, Odayme Quesada from Los Angeles and Jannike Nikander to join here and present their papers. As usual, this is a fairly informal walk through the PDFs by the authors, just in brief describing the highlights and maybe provide some additional information wherever interesting. And then we have always a little room for discussion. So if you ever have a question, you can either just speak up or type your question to the chat box that you find at the bottom of the screen. And then we can address that. So today's topic is a very interesting one. It's about females and cardiovascular disease, and specifically perfusion. And we have two very interesting papers that both were recently published. And we'll jump right into the first one. It's called Temporal Trends in Angina, Myocardial Perfusion, and Left Ventricular Remodeling in Women with No Obstructive Coronary Artery Disease over 1 year follow-up. Results from WISE-CVD. WISE stands for Women Ischemic Syndrome. Sorry, I forgot the last one. Women Ischemic Syndrome Evaluation. And the team around Noel Berry-Mers at Cedars-Sinai in Los Angeles is arguably the top team to address this. The WISE project has been going on since numerous years and has generated a lot of very interesting data. So I'm really looking forward to this one. So I'll hand over to Odayme to present her paper. Thank you.
And thank you again, Mattia Frederick, for this invitation on behalf of our co-authors and our senior authors, Dr. Jannike and Dr. Berry-Mers, for this invitation. And so we're going to jump right into the background. So as many of you may know, individuals presenting with signs and symptoms of myocardial ischemia and found to have no obstructive coronary artery disease on invasive angiography, which we refer to as INOCA, are increasingly recognized. Women are actually more likely to have INOCA, with up to 2/3 of women undergoing coronary angiography for suspected ischemic heart disease found to have no obstructive coronary artery disease. And despite this absence of obstructive coronary artery disease, what we have found through WISE and WISE-CVD studies is that INOCA is associated with increased risk of MACE. And despite more studies now, more recently on this topic of INOCA, we still have a lot of work to do. So when we first were thinking of this analysis, there really wasn't a lot that we knew about the progression of myocardial perfusion and left ventricular morphology and function over time in women with INOCA. And also, we didn't really have data on how changes in anginal symptoms, myocardial perfusion, and LV morphology and function are related over time in women with INOCA. And so with this in mind, we decided to investigate the temporal trends from baseline to 1 year follow-up in angina, myocardial perfusion, and LV remodeling and function in women with signs and symptoms suggestive of INOCA, and then the relationship between these changes. And so, as was mentioned, we used the WISE-CVD study, which, as was said, is the Women's Ischemia Syndrome Evaluation Coronary Vascular Dysfunction Study. And in order to be enrolled into this study, women had signs and symptoms of ischemia, and their treating physician actually were the ones that ordered an invasive coronary angiography. And if we found that, and then only women who had no obstructive coronary artery disease were actually enrolled into the study, into this WISE-CVD study. And we defined obstructive disease as less than 50, no obstructive disease as less than 50% stenosis in any epicardial artery. And so really quickly, I'm going to jump to figure 1, which is the flow chart for WISE-CVD, just to give you a sense of the population that was included in our study. And so in the actual enrollment was 437 women. As I said, these were the women that had these signs and symptoms of INOCA and underwent coronary angiography and were found to have less than 50% stenosis. We were able to collect demographic and clinical data on 429 of them, but then ultimately had baseline cardiac MRI performed in 374 women. And just to mention this was done at 2 sites, which is why you see the CSMC, which is the Cedars-Sinai Medical Center site, and University of Florida. And then as you see here at the bottom of our WISE-CVD flow chart, 214 women had a 1-year repeat research cardiac MRI. So the cohort that was mostly used for analysis was these 214 because they had both the baseline and the 1-year follow-up cardiac MRI done. And just very quickly, I want to go over the Seattle Angina questionnaire, since this is what we use to evaluate angina. And this has been this is a validated tool that's been used both in women and men. And it's divided into 5 subscales: physical limitation, angina stability, angina frequency, treatment satisfaction, and disease perception. And then there's a shorter form of the SAQ, which is the SAQ-7. And that one evaluates physical limitation, angina frequency, and disease perception. And just to give you a framework, these are a score 0 to 100, and a higher score indicates a better quality of life. And also just want to point out that a change of 10 points is considered clinically relevant. As was mentioned, women underwent cardiac MRI at baseline and 1-year follow-up using a 1.5T. We had rest and pharmacological stress first pass myocardial perfusion performed with mostly adenosine, but some patients, regadenoson was used as a stress agent. And of course, gadolinium-based contrast was utilized. And so jumping to the results, we'll start off with table 1. And here we have the demographics and baseline clinical characteristics. We see in this table 1 that women on average were 55 years of age. Close 39% had a history of hypertension. Close to 42% were ever smokers. The majority of our women are postmenopausal as study entry at 72%. And then here we have BMI averages 29. Their laboratories are shown here. And I just want to point out that when we're looking at angiographic findings, most of the women were actually between 20% and 50% stenosis at 83% of these women. And about 9% had what we called no CAD, which is less than 20% stenosis in any coronary artery. And so, and here we see the medications. Not a good number of women were on statins, about half, 45%. We had 35 on beta blockers, 29 on nitrates, 26% on ACE or ARBs. Very few women at baseline were at ranolazine at 7%. And so going to our main findings, we jump to table 2, and here we see the temporal trends in angina using the Seattle Angina questionnaire. And so when we look at the 5 subscales, we really see that we have a statistically significant improvement in 4 out of the 5 SAQ subscales. And then the SAQ summary score was also statistically significant, as was the SAQ-7, that shorter SAQ. We did see an improvement that was statistically significant. The reason I highlight the disease perception and the SAQ-7 changes is because, as you remember, I mentioned that a greater than 10 point improvement was clinically significant. And so we see that in the disease perception and in the SAQ-7 Seattle Angina subscales. And then jumping into table 3, here are the temporal trends related to the CMRI variables. So we start with the rest and pharmacological stress hemodynamics. And what you can see here is that for the peak stress systolic blood pressure, there was an improvement that was significant, as was for the rest diastolic blood pressure. Looking at the MPRI, we see improvements in the mean myocardial perfusion reserve index of 0.2, and that was significant, as was the subendocardial and the subepicardial. And then looking at LV morphology and function measures, we have a statistically significant improvement, decrease in LV mass index, and mass to volume ratio. And here in figure 1, you have essentially a visual representation of these primary findings, where you have this improvement in SAQ-7, you have the improvement in MPRI, the decrease in the stress systolic blood pressure, and the decrease in the LV mass. And so table 4 is a sub-analysis that we did because we thought it was very interesting that in our cohort, 56 women had persistently low myocardial perfusion. And what we used to define low myocardial perfusion was the cutoff of less than 1.84. And the reason that we use that cutoff is because in our prior studies, our WISE-CVD study, that 1.84 cutoff was was correlated with invasive angiography coronary reactivity testing as used to define coronary microvascular dysfunction. So that was the reason we used that cutoff of 1.84. And what we found was that when you compared the women that had persistently low myocardial perfusion, meaning their MPRI remained less than 1.84 over a 1-year period, that quality of life score was lower at baseline for these women with persistently low myocardial perfusion. And we also see that the SAQ-7 at baseline was also lower in women with persistently low myocardial perfusion. So that was a sub-analysis that we did. And then I will jump back to our last results, which essentially were here, where we did a logistic model looking at significant SAQ-7 improvement, again, a greater than 10-point improvement. And what we found is that there was a lower odds of clinically significant SAQ improvement associated with hypertension history and higher SAQ-7 at baseline, odds ratio of 0.4 and 0.95 respectively. And then when we looked at clinically significant SAQ-7 improvement, we see that there was an increased odds associated with higher LV end diastolic volume and time to peak filling rate, with an odds ratio of 1.1 and 2.4 respectively. And so this study was the first prospective study of women with INOCA with repeated advanced cardiac imaging demonstrated concordant trends in angina, myocardial perfusion, and LV remodeling and function over a 1-year follow-up. And I like this summary. This best summarizes our main findings, the clinical perspective box. So essentially what we found was that in women with ischemia and no obstructive coronary artery disease who were clinically treated with medications over 1 year, we did see these concurrent temporal trends towards improvement in angina, as I showed you, myocardial perfusion, and cardiac morphology. We found that abnormalities in left ventricular morphology and diastolic function at baseline were predictive of clinically significant improvement in angina at follow-up. And we found that a history of hypertension was associated with lower odds of clinically significant improvement in angina at follow-up. And in terms of the implications, our findings suggest that in women with ischemia and no obstructive coronary artery disease, is INOCA women, symptoms may be a good surrogate for those with more severe disease, as I showed you in table 4 in that subgroup analysis. And we also, our findings support the use of this non-invasive modality, cardiac MRI, to follow changes in myocardial perfusion and cardiac remodeling, which can be used in future studies of INOCA trials. And so that's the conclusion. If there are any questions, would be happy to answer them.
Thank you very much. Great. We are already with the time a little bit advanced, but just briefly, first of all, I think it's great news that apparently the symptoms associated with microvascular disease, or primarily microvascular disease in women, seem to be modifiable, or that treatment may be helpful. You're mentioning here the medication, but was there also, were there other interventions like lifestyle, like exercise, or any of that?
Yes, so that was what was difficult for us. We thought about trying to assess medications, because one thing that was interesting about this cohort, unlike our clinical trials, which we've done a few trials where we've made specific interventions and kept everything else consistent. In this one in particular, it was really up to the treating physician to make changes, whether those were medication changes, which when we tried to look at that specifically, we just didn't have the power to do that. And there were too many combinations and too many changes, and we only had limited assessment of that. So that's why we were limited by our assessment of medications. But as you mentioned, yes, of course, there was likely lifestyle changes. And the DASI, that was our way of being able to measure physical fitness. So we do know, but that was something that we saw, likely women did have improvements, maybe related to that, to either physical fitness or lifestyle changes that we weren't able to adjust for.
Okay. And then another question very quickly, was there a separate, you mentioned that there were subgroups, those with no CAR, so absolutely no coronary artery, and those with, I would call some CAR, so they had some coronary artery disease, but less than 50%. Did you perform a separate analysis? I mean, the numbers for the no CARs were relatively small, but I just was wondering whether you analyzed.
Tried. Yeah, so that's a wonderful suggestion. Actually, that was a suggestion that Dr. Pepin also had when we were reviewing the initial results of this. But because we were limited by such a small sample size, and the ones that were less than 20%, we weren't able to do that. Yeah.
Okay. Thank you. And then there's a question from Dr. Rafi. What was the frequency of diabetes in these patients? Do you have a ballpark number?
Yes.
Was it an important confounder or an important?
So our diabetes was 10.6%. So these women are actually not. Yeah, that's why we didn't add it to our model.
Okay, thank you very much, Odayme. So an interesting observation here, of course, was that the quality of life was associated with perfusion, and that points to the fact that myocardial perfusion may indeed be important in terms of how these patients evolve over time. So Odayme, could you unshare your screen? So,
yes.
So when it comes to perfusion, of course, we're talking about women, and we know that especially elderly women, they have another disease they have other diseases that also affect microvascular function, and the most extreme one being Takotsubo, the less extreme one being HFpEF. So one hypothesis that I have pondered many times, and just want to throw that out here, it could actually be that mild injury, for example, in hypertension, may cause edema. Edema would cause capillary compression, would reduce perfusion. And then over time, if edema persists or comes back often, could eventually even lead to fibrosis. So that's just one, I think, interesting aspect in terms of physiology. So there's one question, and that has to be the last one, from Dinesh Kaira. Can you speculate why no relative BW, MPRI, and angina? Maybe Dinesh, maybe you can unmute yourself and just briefly say what you exactly mean by that.
So sorry for all the abbreviations. Yeah, it's a great analysis. I want to find out why there was no improvement, the relationship between the improvement in the myocardial reserve index and your angina. I mean, on the one hand, you say symptoms correlate with the degree of perfusion impairment. That's your summary. And then you say that there's no relationship between the degree of improvement in the perfusion index and angina. So I understand it's a small.
Okay, so the relationship between the perfusion and the symptoms, so was not.
Yeah. So you bring up a good point. So we expected it to correlate because we've seen that in our prior studies. And in fact, what we have found is that in the studies that is correlated are mostly studies where myocardial perfusion has been done invasively. So then our hypothesis was that perhaps angina in this cohort, this larger cohort of INOCA, because this cohort is composed of women with coronary microvascular disease and women without, even though they're under the INOCA umbrella. And so it's possible that angina could be caused by other mechanisms, and therefore the improvement in MPRI did not correlate with the improvement of angina. So we think that there just may be other mechanisms by which these women have angina that's not just specific to myocardial perfusion. But again, we also think that because we did this non-invasively, this myocardial perfusion assessment compared to other trials where we've done it invasively and also we've also, when we do clinical trials, we're able to control with what our exposure is, and a lot of times medications, and that's where we really have seen those correlations of MPRI improvement and angina improvement. So those were our hypotheses.
Yeah, thank you. In the interest of time, we'll now dig a bit deeper into perfusion, and we will probably go a few minutes over time just to be fair. So I welcome Jannike and Nikanda from the Karolinska Institute, Department of Clinical Physiology, to present their paper published in Scientific Reports entitled Females Have Higher Myocardial Perfusion, Blood Volume and Extracellular Volume Compared to Males. And that was an adenosine stress cardiovascular MR study. Jannike, thank you for joining.
Thank you so much, Matthias, and also thank you for inviting us to speak about this paper that we recently published. And I'm just going to jump straight into this, that knowledge on sex differences in myocardial perfusion, blood volume, and extracellular volume in healthy volunteers is scarce and somewhat conflicting. So we decided to investigate this quantitatively by using CMR. And what we did was Peter Kellman recently developed a quantitative perfusion method, which renders pixel-wise maps with the possibility to measure in one single map. So we included, healthy volunteers, 43 that were non-smokers, had a normal 12-lead ECG, no cardiovascular medication, history of asthma, cardiovascular disease, and no kidney disease were included. And then we gonna go straight to figure 1, where we look at the timeline of the Cmr scan that we performed. So going from left to right, we started off doing scouts and cinis, and then we performed native T1 at rest, and then we started our adenosine infusion, and we did native T1 at stress, and then we gave gadolinium contrast. And during first breath perfusion, we got both them perfusion stress maps and also blood volume maps during stress. And then we stopped the adenosine infusion and we took a 10-minute break. And then we gave contrast once again to get our perfusion maps at rest and then blood volume maps at rest. And then we doubled up to do double dose, and we waited 10 minutes to reach contrast equilibrium. And then we performed and post-contrast T1 mapping to get our ECV at rest. And then we once again started the adenosine stress infusion and imaged post-contrast to get stress ECV. And I just want to stress here that we really did indeed have stress ECV, because using native T1 at rest and stress, and then post-MOLY at rest and stress, we were able to offline have both rest ECV and stress ECV images. And then we analyzed all of these maps by conservatively drawing a region of interest in the short axis, in all of the short axis maps. And these are going to table 1. Our volunteers were predominantly young, of course. You can see here 26 years. And as you can see, looking at sex differences, those variables here that have a star were those who where there were differences between the sexes. And interestingly, moving forward to table 2, no, I'm going to go over here to figure, sorry. So these are our results for looking at myocardial perfusion. And then we have rest and stress, and we have females in white and males in black. And as you can see, females have higher myocardial perfusion. And then we have stress, females in white, males in black, and we have a higher myocardial perfusion. And both men and women increase their myocardial perfusion as a response to adenosine stress. Looking at extracellular volumes at rest and stress, where we still have females in white and males in black, you can see that females have higher myocardial ECV at rest and at stress, but both men and female increase their extracellular volume as a result, as a response to adenosine stress. And then looking at myocardial blood volume, we see females in white and males in black, and there is no statistical difference between males and females with regards to blood volume at rest, but there is a difference at stress. And both men and female increase their myocardial blood volume as a response to adenosine stress. We then performed regression analysis looking at myocardial blood volume and compared to extracellular volume to understand if these two variables correlate with each other. And we have an R-square here of 0.35. And then looking at the differences in the change from rest to stress in percentage points for extracellular volume and myocardial blood volume, we see that there's no difference in the response, which suggests at least that myocardial blood volume indeed do increase during adenosine stress, and so does the extracellular volume. And then looking at table 2, where we have our physiological variables, we can see that there was no sex differences between males and females with regards to rest or stress heart rate, and no differences with regards to rate pressure product or change in rate pressure product or in myocardial perfusion reserve. So then we moved forward trying to understand these sex differences that we observed in all of these parameters to understand if sex is an independent variable with regards to this. And looking at perfusion at rest, we see that both sex and myocardial blood volume are independent variables. And for stress, it's only it's still both sex and myocardial blood volume that is independently contributing to this. Now looking at myocardial blood volume, we see that the only contributor is perfusion during rest, which is the same during stress. And then looking at extracellular volume, we can see that both sex and hematocrit is contributing during rest. And then looking at stress, it's still hematocrit. So from this, we conclude that females have a higher myocardial blood volume and perfusion and ECV, both at rest and during adenosine stress. And also that sex is an independent contributor to perfusion and ECV beyond all their physiological factors that differ between the sexes. And they provide mechanistic insight into sex differences in myocardial physiology.
Thank you very much. That's interesting. Your audio at some points broke up, but I hope that still, especially with the help of the PDF, everything was clear to everybody. There's one question from Odayme Aremu, and says, how did you obtain your MBV, so your myocardial blood volume? I might have missed that part. So I think it's part of the quantitative perfusion, right?
Yes, so it's a part of the output that we get from performing a quantitative perfusion. It's one of the output from the scanners that we get clinically.
Yeah, yeah. And then there's a question from Dana Peters. She's surprised that the myocardial blood volume only increased by that extent and not more. And whether it was related to adenosine and whether that would have been different with dipyridamole. I think we know that that adenosine and dipyridamole have actually relatively similar responses, while actually interestingly our own research has shown that that a breath hold actually has a stronger impact on myocardial blood volume and perfusion than adenosine. But for now, that was the question. Would you have expected more, or when you compared with the physiology, you would have expected, Jannike?
Well, I think it's kind of hard to say because it's notoriously difficult to measure blood volume in you know, in a healthy living heart. But looking at that it's 4 percentage points for both ECV and myocardial blood volume, I still think we are as close to the results as possible right now, at least with the knowledge that we have now. I would like to perform a validation study of these myocardial blood volume maps, doing, you know, in pig models, and where we do technician labeled blood. And this is a plan to do, but I'm actually, I don't know, I didn't expect anything, and this is the results that we had.
Actually, I'm not entirely sure whether the nuclear methods will provide a lot of additional validation power, but that's of course open for discussion. I mean, it's probably the best we have right now. Yeah. There's another question from Attila Todd from Budapest. Would the sequence used for T1 map have had an impact because they may be differently impacted by heart rate? So do you think that stress is T1?
Yeah. Well, sorry for interrupting you, Matthias. That is a very good question. So the sequence used for this T1 was Molly 533 in seconds. So all measurements in seconds, both the inversions and the readout. And I would say that is the most robust Molly sequence with regards to heart rate. I don't think that affected the results with regards to the extracellular volume, no.
Yeah. And then last question was here, and then if you wouldn't mind unsharing your screen, were the native T1 values different between rest and stress in males or females? So were there differences in the native T1 values basically before during stress?
I have not performed that analysis within this cohort, but you know, from all the data and all the analysis I've done before, yes, I would think that of course there would be differences between males and females. You know, all studies show that females have higher native myocardial T1 values, and I guess that this would be the same in our data.
Okay. Great. If there are not any other questions, I want to really cordially thank both of you. Before I let you all go, I wanted to just point to, oh, so that's the wrong screen here. Want to just point you all to the next CMR Journal Club. That will be beginning of September. Before I go to the papers, I want to just highlight one of the papers that recently was published on outcomes of cardiovascular MR imaging in patients recently recovered from COVID-19. Interesting paper, although some of you may have seen there's a vivid discussion on Twitter on some of the data. There are apparently issues with the data, but still I think the message is important and good. Another paper I wanted to point you at is a very interesting editorial on ejection fraction and how we classify that. I think that's a very nice one by Michael Böhm and others. And then for our next journal club in September, so first Wednesday of September, the following two papers will be discussed. One is from Germany, Florian von Knobelsdorff, and it's called Influence of Contrast Agent and Spatial Resolution Myocardial Strain Results using Feature Tracking. And then another one by Katie Fischer from Switzerland, Christoph Greni as a corresponding author will join us then, and present the paper called Feature Tracking Myocardial Strain, Increment Improves Prognostication in Myocarditis Beyond Traditional CMR Imaging Features. So next journal club will be about strain. So I hope that I can see many of you back there. And want to again thank you, Jannike, thank you, Odayme, for joining and the beautiful presentation of the papers. And wherever you are, I wish you a wonderful rest of the day or evening. Thanks, and hopefully until soon. Bye-bye.